If you were to speak to your new grad self, what would you say?
We've seen PAs grow so much and just change the entire field of medicine. I love that we're part of that groundbreaking new profession. I would not go back and change anything. I would tell myself it's worth it. Being a physician assistant is awesome.
Justin Lautenbach is a Canadian certified physician assistant and a McMaster PA graduate who works in 3 specialties at once: orthopedic surgery, chronic pain, and aesthetic medicine. We talk about how hiring a PA is one of the smartest business decisions a physician can make, how PAs can get started in aesthetic medicine, and what the new generation of PAs needs to hear about opportunity ownership and knowing your worth. Welcome to the Canadian PA Podcast.
I came from an undergraduate degree in health science at Brock University. I graduated from there in 2011, and then I started the McMaster education program that same year, 2011, and graduated in 2013. I started my initial position in orthopedics with Dr. Rabinovich at the Brantford General Hospital in November 2013, and then in 2016, we left the hospital and started an outpatient orthopedic practice that has since evolved into ArthroBiologix, which I think we'll touch on a little bit. And at that same time, just due to the nature of the change, and I started working in pain care in Burlington at a clinic called Burlington Pain Care. A couple of great physicians there as well. And then just the nature of the evolution of ArthroBiologix has gotten really busy. I've stepped back a bit from Burlington Pain Care, but I'm there 1 day a week and I'm working at ArthroBiologix 4 days a week. So I'm pretty much Monday to Friday now, mixed 80 to 20% between the 2 clinics.
So you technically work in 3 specialties at once?
I'm working in outpatient orthopedics and chronic pain, and now in the last 2 years starting this aesthetic Botox company on my own, which is taking up a lot more time on top of the other 2 positions. But that's been something I've been really passionate about in the last year especially, but really the last 2 years. So really, ArthroBiologix is an outpatient aesthetic or outpatient orthopedic practice, and then the chronic pain, and then now a little bit of this aesthetic medicine as well on the side.
Fantastic. So I'd like to take things back a few years. What drew you to the profession, and how did your path unfold before getting into McMaster's PA program?
I guess much like yourself, I was one of the earlier classes, graduating in 2013. And when I was going to Brock University, I was part of a program called Med Plus, and it's an extracurricular program that people that are interested in medicine, a field of medicine, and that could be any profession. But we got introduced to physiotherapists, occupational therapists, chiros, and different medical specialties. And I wasn't sure exactly what I wanted to do. I was pursuing medicine, but I wasn't sure I was really headstrong on the long haul of applying to medicine and getting in and really doing that. And in my 3rd year, I had one of the first graduating classes, Donna. She came in and spoke to us. She works in family medicine in Niagara. And she came and told us about a PA. And first of all, I'd even heard of a PA. And she's sitting there as a PA telling us about this profession and her quality of life and what she can do and the training. And honestly, I left that day and I was like, I'm going to become a physician assistant. It ticked every box for me, from just being patient facing without having the long haul of medicine, which I wasn't even sure I really wanted, but I could still practice in these fields that I was excited about. So I had that sort of 30 to hour minute session with Donna, and I knew then that's what I wanted to do.
That's incredible. And so you went to McMaster's PA program, 2-year program, as first year's didactic, second as clerkship. Looking back from where you're sitting now, what did PA school actually prepare you for, and what did it leave you to figure out on your own?
I think like all of us, the 2 years is a whirlwind. It's such a blur and you're learning so much, but it's just continuous. You learn one thing and then the next class you're learning something different and so on. So it just keeps going. And then you try to become applicable with that knowledge in your 2nd year of clerkship. But I think beyond the science, beyond the sort of medical education, the biggest piece I took away was the need for communication and how communication is a clinical skill all on its own. How we explain something to patients really shapes how they experience it. When a patient, I find especially in our practice here, when a patient feels confused, they're a little more anxious. And when the patients are a little more anxious, they experience pain a little bit more differently and outcomes tend to suffer a bit more. Being able to reframe medical knowledge for patients in a way that they can understand is so important. And it allows you to build that trust with patients. And then when patients trust you, we know that patient outcomes get better. They're more likely to follow your medical plan. So I think for me, less so about the medical knowledge, just like how good when you watch some practitioners are with that communication, how much farther it goes. So I guess getting a little bit away from having to say the right thing and learning to say things in the right way.
Depending on the patient that you're working with, it sounds like. And your first role was in orthopedic surgery. What did that job teach you about becoming a competent new grad, apart from the communication piece?
Yeah, I graduated and I started work and I was so excited to start contributing, being a physician assistant and getting paid and going to work. And you're excited to start doing a job. And then I quickly realized how incompetent I was. I had all this knowledge and these skills, but I wasn't that applicable. I felt like starting as a new grad was very much like starting a new placement. And so but then the expectations are higher. You're getting paid. You feel like you should be contributing more, but you still feel like a learner. I think if for new PAs, especially if they're graduating and you're going through this, I think it's good to just take a step back and realize like the journey and that learning doesn't end, especially in those first 6 months to 2 years. There's so much learning. And I think we all know that there's continued learning, but you think that you're going to be better at it at the beginning to some extent. And so I just remember that feeling of inadequacy and like how humbled I felt and just knowing like I have a long ways to go. It's a long road to get to having expert skills at anything, and you just got to stick with it and continue to learn, to continue to put it in the hours, and those skill sets start to come and you build on them and you just start to feel more competent. But it's not an immediate process. So those first 3 to 6 months it can be just a bit daunting when you first step into it, but I think it's just sticking with it and appreciating that that's the expectation for PAs. You're not expected to graduate and get paid and all of a sudden be this amazing contributor right off the bat.
Yeah, I like your analogy to just being on a new clerkship rotation. So what did you do to overcome, like I know you had mentioned 3 to 6 months is usually pretty rough, even though you may have worked in that specialty as a clinical clerk. So what did you find was helpful to actually get competent at the job? Because I know it was humbling not knowing everything.
I think it's a lot of studying. For me, this probably comes down a little bit more to that communication factor as well. Is if you can, one thing that you can do in any field is go in and talk to the patient, right? And start building out establishing that relationship and that rapport with the patient, because you don't need to know anything about any specialty to go in there and start a conversation. And I think a lot of PAs come out and they're very good at taking histories and doing physical exams. And maybe you can't put a full plan together and you can't come up with a full diagnosis or differential. But I think if you're able to be brave and go in and just have a conversation with patients, even in feeling overwhelmed, like you don't quite understand what you're going to be doing in that room, that you can come out and then putting yourself in that position. I feel like making mistakes is why you have these supervisors, and you make mistakes, you're way more likely to learn versus just shadowing. If you're just tailing behind someone, you're taking it in, but it's not the same as having to try to do it by yourself and coming up with that differential, being willing to like make a decision and be wrong. And then you learn from that. And then you can take that home and study and get that feedback and then go into the next patient and do it again.
How long have you been practicing as a PA now?
I graduated in 2013 and I'm still with Dr. Rabinovich now. It's changed a lot, but I'm still working with Dr. Rabinovich in the field of orthopedics, and we do a lot of procedural medicine and the pain care since 2016 as well. So I'm just hitting my sort of tenure in pain management as well.
And how would you say confidence in your competencies are now compared to when you had first started?
No, it's a great question. It takes a long time to become an expert in the field, and I'm certainly not an expert in the field of orthopedic surgery. There are things that we do here, such as like interventional procedures and injections, and I've certainly become an expert in that field. It's something we do a lot of, but as a whole is an enormous field. You just think of even pediatrics. We don't see a lot of pediatrics. So like when it comes to treating pediatric orthopedics, I'm nowhere near an expert. Even each specialty has its niche within that specialty. And so I feel very competent in the job I'm doing now in the niche field that we're in within orthopedics. And same within chronic pain, but then chronic pain also has its subspecialties. And yeah, I guess from a day-to-day perspective in the job we're doing, sort of patient care we're providing, I feel very competent. But I also know that if I was to switch into a different orthopedic role, that although some of those skills are transferable, there would still be some learning and things that I would not necessarily be an expert in.
Yeah, excellent. I think that's a good segue into what ArthroBiologix is before going into how you co-founded it.
Yeah, ArthroBiologix is an outpatient orthopedic practice. So we specialize in regenerative medicine and treating patients in that middle ground of non-surgical practice. When we were in the hospital in Brantford, we were part of a big surgical practice. Dr. Rabinovich is a foot and ankle surgeon, and there's pros and cons to working in hospital settings and in private settings. But there are committees that are responsible for budgetary confinements and resources, and making sure that resources are allocated evenly amongst different specialties and patient care and staff. And so change can be slow because of that. There's people that have to make these decisions. In 2016, when Dr. Rabinovich chose to leave, we wanted to be able to make some of those decisions on our own. We wanted to be more responsible for change and making that change fast and not having to rely on committees to make those changes. So that's what sort of brought on the initial change. We did not appreciate the need for this niche market of outpatient orthopedic medicine at the time. So when we left, we were seeing like 10 to 20 patients a day, and we had a very small practice, wasn't even called ArthroBiologix, and we were just seeing 10 to 20 patients semi-surgically, but really for like non-surgical management, conversations, counseling, and then starting with some injection therapy. And then that field it just evolved in terms of the need. And this subset of patients that are maybe followed by a surgeon and are waiting for surgery, but then they don't either want surgery, they don't qualify for surgery, maybe their medical conditions are too complicated for surgery, and they're looking for management, right? And a lot of surgeons have such busy surgical practices, they don't necessarily have the time to meet this middle road. And so that became our specialty, is this sort of middle ground. And it was a very slow process, which is why I started working in the field of chronic pain, because we didn't have enough time. Dr. Binish wasn't sure I would even be able to stick around as a full-time PA when we transitioned. And now we're seeing, as a clinic, we have 20 providers and 8 physician assistants, and we're seeing 200 patients or so a day sometimes. So it's an enormous practice. It just goes to show you how much need there is in this field of outpatient orthopedics.
That's incredible. So I know that PAs are seen as healthcare providers that work under the supervision of a supervising physician, but it sounds like it was more of a partnership in terms of working and co-founding. Can you tell us a little bit about what that relationship looks like and why it may not be as conventional as like the typical PA-MD supervisory relationship?
Yeah, absolutely. We see a lot of follow-ups. That's probably one piece of it. Our job, although we see a lot of orthopedics because we don't subspecialize within orthotics, so we're seeing a mix of everything, upper and lower extremity. When we transitioned into this outpatient practice, I've been with doctors for almost 3 years, and I think the best physician PA relationships are built on some trust and working like colleagues or teammates more than that employer-employee type of relationship. Certainly with medical directives, there's a lot of autonomy for PAs depending on the specialty and the complexity of the medicine. It just so happens in our field that patients are looking for good care and they're looking to build relationships and rapport with a provider. And I don't know if it's because we're not necessarily a specific surgical practice, but patients really want to see the same provider. They want to see the same PA. They're not waiting to see the surgeon. A lot of times they don't necessarily want to see the surgeon. They want to see the same provider that provided them a good treatment on their last injection or assessment that when they were here. I think in that way, we've slowly evolved into a practice where we can see patients autonomously but work alongside one another, where if I do have questions or concerns or patients want to see the physician and we want to bounce ideas off one another, there's certainly continuity of care and he's always there beside me, but we can work alongside each other as opposed to this sort of dynamic where I'm seeing someone and he's coming in behind me every single time. So we can actively seeing patients together.
Most PAs do follow a traditional employment path, and your career has taken a little bit off the road, like the beaten path. So you have co-founded practices and you worked across multiple specialties. Was that intentional or did it evolve?
I think like most careers, it's evolved. There was intentionality in choosing orthopedics and wanting to work with Dr. Rabinovich and in the sort of region that I chose to work in. But I'll tell you, it was scary. In 2016, when Dr. Rabinovich told me he was leaving the hospital, that was like a 1 or 2 month notice. And then he told me I may not be able to be with him anymore as a full-time PA because the practice just couldn't sustain it. The market as PAs too was not extremely hot. There wasn't an ample amount of jobs out there. And so it just so happened that this opportunity opened up in Burlington at the pain care clinic where an international medical graduate was working and he had gotten into a residency here. And so they were looking for someone to fill that position. And it blended very well, the timing between working part-time there and part-time with Dr. Rabinovich at ArthroBiologix. And then sort of set sail into a bit of medical legal work and something else that you don't necessarily have to be a physician assistant to do, but working in intake assessments for the medical legal industry with motor vehicle accidents and things like that. In that pain care clinic is where I started doing some of the Botox management for prophylactic migraine treatments. And then just that and being introduced to new people along the way, I've had the fortune of having so many great mentors and some that provide Botox cosmetically. And I've gotten the nudge and the push to say, you should be trying this or considering this. And I hesitated for so long, but eventually, just with the help of some of these mentors, took the leap of faith and said, I'm going to give this a try. And if it fails, but that a couple of years ago was the push I needed to just start this Hamilton Botox adventure into sort of the aesthetic medicine. But I think without doors closing and leaving the hospital, I would never would have been in pain care. Without being in pain care, I never would have used Botox. And sure, there's intentionality and in making these decisions and choosing to walk through some of these doors, but the doors also have to open up and present themselves in some ways. So I wouldn't say I necessarily was pursuing aesthetic medicine, for instance, or chronic pain management. But I feel blessed in that some of these opportunities have worked out very well and that I chose to walk through some of these doors. And then there's other things like the field of medical legal work and MVA stuff that I don't do at all anymore. I just found it wasn't my niche and I didn't love it. And I don't do that at all anymore. So I don't regret trying it and doing it, but you don't know what's going to work for you until you try some of these things.
Yeah, I've actually met Justin in real life, and he's very personable and very friendly and a great person to be able to work with. For just a quick question for new grads, if they want to be able to network, maybe not with the intention of jumping into another field, but wanting to build relationships, build their network of mentors or people that they can speak to, what advice would you have for someone like that?
I think probably much like yourself, and you graduated a little before I did, there were none of us, right? We had no orthopedic PAs or PAs that were in the field of sort of procedural medicine. And so there was really no one to ask these questions to, even from a financial perspective, when it came to just advocating for yourself and find your sort of hourly wage and your worth. But now there's a lot of us, and many people here may know of the OrthoPA network, and I think we may chat on it a little bit, but the OrthoPA network run by Ultrasound-Guided is amazing and a great resource for up and coming PAs or current PAs or practicing PAs to just come and explore and meet other PAs working in the same field. And I think a great place to find some of these mentors. There are so many PAs that have been in the field for 1 or 2 years, but also 10 plus years now. And so I think that's a great way to meet some potential mentors and get some guidance on salary negotiation and just adventuring and even the entrepreneurship rules, the possibility of things like that. And yeah, I think there are a lot of resources when it comes to just hire PAs, just like PAs that have paved the path before you and being able to communicate with them. But then there's also, those PAs also have connections with a lot of physicians and supervisors that can also answer a lot of questions as well.
All right. So I just want to go pivot a little bit and talk about, you do a lot of procedures. Like that seems to be, as you had mentioned, your niche. That's something that you really enjoy. So what drew you towards procedural medicine, and how has ultrasound specifically impacted your clinical work?
Anybody that's followed like OrthoPA network or my page a little bit knows I love ultrasound. And I've always loved procedures. I thought I'd go into emergency medicine. The opportunity didn't present itself when I first graduated location-wise, but I love the portion of medicine where you have an acute issue that you can do something about physically with your hands and change it, whether that's suturing a laceration or splinting a fracture or doing an injection. There's this concrete before and after, an immediate change, immediate benefit and satisfaction in those procedures. I personally, I'm just in my own personal life, love working with my hands and doing things. And so it fits very well with going into this aspect of medicine. But that's what really drew it to me the most. I love the fast-paced nature of it, seeing patients and doing something over 10, 15, 20 minutes, and then seeing the next patient. You build a little sort of rapport with the patient, but there's not this like long hour-long sessions with patients, which some people love and they're meant to do. For me, I love the acuity of it. I love the procedural aspect, just working with my hands. And when it comes to ultrasound, it has revolutionized the way we are practicing in orthopedics in our practice. When I graduated 12, 13 years ago, we were doing a lot of injections at the time, and those were all blind injections. We didn't use ultrasound at all. And that was foot, ankle, knees, and shoulders. Do landmark as best as you can, like most practices do. But once we started using ultrasound and you become competent in using ultrasound, the accuracy of your injections, they go way up. All of a sudden, your efficacy is going way up. The comfort for patients during the procedure is significantly improved. And now to the point that we practice here at ArthroBiologix with like 8 or 9 ultrasound machines, and PAs that train with us and PAs that are working with us now only ever use ultrasound. So it's actually shifted so much that it's not something, the joke here that the PAs could never do a blind injection. They don't even necessarily know how to landmark and do a blind injection, which is a good thing. This is why should you ever have to necessarily do it that way? But it's just interesting that most people they learn first blind and then they transition and learn ultrasound, but it's becoming so commonplace, especially in our practice, but where it'll just be common nature to just have a procedure done under radiographic guidance. That blind procedures will probably be done less and less with time.
That's interesting you say that. The hospital I work at, like 50% of the surgeons do it blind, and there's like a smaller percentage that do use ultrasound guidance. Otherwise, we're referring out to interventional radiology for image-guided injections, depending on what we're looking for. All right. For PAs who want to be able to build competencies in performing procedures, what does the process of becoming good at that skill actually look like in real life?
I think at the beginning, when you're new and you're learning a new skill, it feels very manual. And I'll just use ultrasound-guided injections as an example, but you're thinking about your landmarks, you're thinking about sterility and the angle of your needle. How do you position the patient? What do you say to the patient? What could go wrong during your injection? And so there's a lot of steps and you're thinking about every single step. Many PAs may know my wife, Deanna Lautenbach. She's one of the clinical chairs at MICRA's Physician Assistant Education Program, and she took her master's in education. And I remember she was learning about the sort of concept of see one, do one, teach one. And that is a little bit of old school thinking. It does hold true in some regard, but it's probably better to think about it as see one, see a few, watch somebody do a few procedures, and then you actually want to break that skill down into smaller chunks. For instance, for an ultrasound-guided injection, you're not going to watch someone do an ultrasound-guided injection of a knee and then step in and do an ultrasound-guided injection of the knee. The number of steps involved in that is actually considerably high. But if you can break it down to say, how do I hold the ultrasound? Like, how do I put my hands on an ultrasound machine? How do I position my hands on the patient to be able to see the image I'm looking for? That step alone could be something you practice on your own. And then you could get a model and practice just an injection. How do I get needle gain under the ultrasound machine? How do I dynamically change that ultrasound while I'm doing the injection in order to get that needle gain back if I lose it? And then how do I do this with one hand? How do I scan a patient while I sterilize the field, uncap my needle, put the needle next to the patient? And then you bring all those steps together and you try to perform an injection. So comfort comes from repetition, but the competence that we're talking about really comes from good feedback. So you want to have somebody watch you do a procedure a number of different times and give you feedback. Because without the feedback, you will become comfortable, but you won't necessarily become an expert or competent in that skill. So I think if you can break any skill down like that into smaller steps and then try to master that step and then put all those steps together to master a procedure. So it's about more than just doing a lot of times, but getting good feedback while you're doing it. So the more you can have an expert in the field watch you do these procedures, the better you're going to get at doing that procedure for sure.
And I often compare reading an ultrasound like trying to look at a snowstorm and understand what's happening. So how did you learn the ultrasound interpretation in addition to the procedure itself?
No, I totally agree with you. Actually, I even meant to mention this. As physician assistants and as physicians, you read a lot of x-rays, you read a lot of MRIs and CT scans, but for some reason, we don't read a lot of ultrasounds. And that still holds true going through the program. And for the orthopedic surgeons and sports med guys I'm seeing come through here, 10 years ago when we started using ultrasound, I felt the same way. I was so intimidated and comfortable enough doing it blind that I was a little bit pushed back against the ultrasound. I didn't really want to adopt this new skill because I had no idea how to use it or what I was looking at. And so I think a little bit of his exposure as much as you can during your clerkship placements and if you can get some hands-on training, but a lot of this just comes on the job for us. So when we break down ultrasound, and I'm developing an ultrasound course as well, but we're trying to get beginner injectors to just to have a sort of to an injection, to have pattern recognition. So it's not about necessarily being able to perform an ankle and a knee and a shoulder, for instance. It's what does a pattern look like? What does tissue look like? What does fat look like versus tendons versus muscle versus bones and joints? And then once you can recognize those patterns, if your anatomy knowledge, you start building that anatomy knowledge, you can start transferring that knowledge onto the ultrasound machine and recognize those structures. And once you can do that, then just getting the hands-on injection skill going it's the next step. But a lot of it is just pattern recognition. So yeah, it was intimidating at the beginning for sure. But it's really, the more times you see it, the more comfortable you feel.
So it wasn't necessarily a course or certification that you obtained. It was more doing and learning as you go.
That's a great question, Anne. So there are courses you can take to get better at ultrasound, but there is no certification in ultrasound. There is a very high level musculoskeletal like ultrasound certificate you can get. That would be something like an ultrasound technician would have when you go to get a formal ultrasound done. But beyond that, there is no like stepwise approach to it. So there are absolutely courses there. And one of the reasons I've started developing this beginner level ultrasound course is that these courses, and I've taken a couple of them, are very expensive. And I'd love to just be able to have a course just for beginners to introduce them to ultrasound, getting them comfortable with that pattern recognition and having some general approaches and just being able to spend hands-on time scanning, because that's what people need, is time with ultrasound with patients to be able to scan those joints. That was part of my rationale for wanting to develop this course for PA. So there are courses out there, but they're often very niche, and I'd love to be able to tailor some of that to whatever sort of practitioners need if they're scanning just shoulders or just hips or just knees in their practice.
And I know that you had mentioned you'd been to several ultrasound courses. You've also worked alongside and taught physicians and PAs that have had some training in ultrasound and have not. So what are the specific learning gaps that you were trying to address when you were developing that ultrasound course?
I think for the most part, what we want to do is have a simplified scanning framework. So like when you're scanning a joint or you're grabbing that ultrasound machine, you have a solid idea of how you want to position your patient and how you want to hold that probe and how you want to place the probe on the patient in order to get the best view possible. Because a lot of this stuff, as we know in medicine, we don't have a lot of time, and the ultrasound is another step. So bringing that step in when you're already comfortable in your practice without it can slow you down at the beginning. So we want to create repeatable protocols where practitioners feel very comfortable grabbing an ultrasound machine and putting it on a patient and understanding the pattern that they're looking for. So you want to have these mental checklists, a sort of idea of how is the patient going to be positioned, how am I going to hold the probe, what's the picture I'm looking for, so that instead of asking the question from a learner of what am I seeing, they start to appreciate I recognize this pattern. And once you can recognize those patterns, then you start moving away from just blind scanning, looking for a specific view. If we can create those just scanning frameworks, I think there's just something that people can build off of, and they can just build that repetition. Some of the common gaps I see are just needle trajectory. So how do you want to start your needle trajectory in terms of the degree to get the right angle to get down to whatever structure you're trying to inject? What happens when you lose your visualization when you're scanning? So you're starting your injection and all of a sudden you don't see your needle, or the view you were looking at isn't what you started with. Like, how do you correct that mid-procedure? And then at the same time, and this is a next level, but this is certainly what happens when we're training our PAs here to come and work with us, is like, how do you manage the patient's anxiety during this procedure? Because it is going to deviate. It's not always going to go well, but you have a real patient sitting in front of you while you're scanning them and you're injecting them, and they can feel very anxious. And when patients feel anxious, their tone goes up, and oftentimes their pain is worse during the procedure. So you got to manage that at the same time.
I really appreciate that. I know that with our intra-articular injections at our practice, sometimes telling the patient to relax in a doctor's office is a lot harder for patients than it seems. And if someone is interested, any kind of clinician, in taking an ultrasound course with you, how would they go about doing that?
OrthoPA Network, I think, is going to be starting a more formal course introduction in the fall, and then maybe in the spring as well. So I think that's the intention for us to run a couple courses a year. But we're also trying to open the door to just training and shadowing. And I personally have no problem bringing on learners and PAs or practicing PAs in the practice that want to just come and watch how we do things here at ArthroBiologix. If anybody wanted to reach out to me personally, I'm okay with that as well. And I can leave, I don't know if you have just notes you leave afterwards, but we can leave my email there. People can reach out via email if they want to just get in touch and have questions or set something up.
I might arrange for that myself.
It's perfect. I love it.
Yeah. Just moving on. So you work both in orthopedics as well as chronic pain. So from my experience, those are very different patient populations who have different approaches and very different outcomes. Now, how do those, like in your experience now, having had experience both sides, ortho and chronic pain, how do those mindsets differ?
I think they're I think as a general rule, when people think of orthopedics, they think of people breaking bones and having surgery. And you think of that timeline, it's often much shorter. So we think of as more of an acuity, that timeline more like 3 to 6 months, for instance, where you're having a problem, you identify that structural pathology, and then you do something to try to correct that, whether that's physiotherapy or strength training or a procedural thing or surgery, and you're trying to restore function to the patient. So in a lot of times in orthopedics, we have a problem. We're looking for what is the cause of pain, right? So what's broken? How do we fix it? How do we restore that function? That's the mindset. And a lot of times that's very targeted. It can be a single joint or two joints, or it's a tendon problem. When it comes to chronic pain, it's a little bit different. So the pathology is often multifactorial. You're dealing with more than one structure. You're dealing with multiple systems of GI and neuro involvement, and it can be multi-joint related. It can be autoimmune mediated, and you have this neurologically amplified pain for patients. And a lot of times their pain is out of proportion to the imaging that we're seeing. So you might see someone with very mild degenerative change, but they're having severe amounts of pain. We're dealing in chronic pain with more of this longevity situation, very long timelines, and we're dealing with fluctuations in pain. We're often dealing with sleep disturbances. We think of things like mood interactions, and a lot of patients are living in fear of pain. So you get this fear avoidance, and then a lot of times in the chronic pain industry, we're obviously dealing with medication strategies. In saying that, I appreciate both. Like I honestly do. I appreciate both pieces of medicine. And a lot of times our orthopedic patients start falling into this chronic pain pattern, especially in our practice where we're dealing with a lot of older patients with degenerative conditions. These patients have conditions that aren't going away. So although they get some benefit from treatments and where we are maintaining function, their condition itself is chronic in nature. And a lot of times it's compounding and they have multiple joints involved. You learn how to have in-depth communication, longitudinal thinking, and how to set expectation management for patients. You learn to appreciate the small wins, that there's not always a fix. It's not necessarily going to get back to normal, that it's not broken, put back together, but learn to manage, learn to live with some of this pain that people have. And so we try to make that as comfortable as possible and make those improvements, but it's not always something where we're going to solve the issue and they're going to go back to normal. And so chronic pain management and having some of these tougher conversations has really helped me in dealing with our aspect of orthopedics, especially where it does fall into a nature of chronic pain in a sense. Different, but there's crossover, and I think both have helped me in the other field.
Great. Now, with regards to injections or procedures that you do in chronic pain, I know for ortho, it's, as you had mentioned, joint or tendon. It's pretty narrow in terms of the different types of places you can inject. But in chronic pain, what are the types of injections that you do?
So we still do a lot of injection therapy. A lot of chronic pain management is neck and back involved. It's just a lot harder to treat surgically. And so patients end up with these chronic pain pictures, especially if there's nerve involvements. At our pain care clinic, we are radiographic guided with x-rays. And so we don't do any facet injections or medial branch blocks and things. So there are some pain clinics that do some very high level interventional procedures. We do perform some paravertebral blocks around the spine, in the lumbar spine, and we do some joint and tendon injections there as well. One of the bigger fields for us in chronic pain is actually migraine management. And migraine management, certainly in large part, is treated with a combination of oral medications and mindfulness and behavioral changes. But then for people that fail a lot of the medications, some of the injections that we perform are Botox injections, so botulinum toxin injections for migraine management under a very strict preempt protocol, it's called, where we inject very specific values of Botox, units of Botox, into very specific targeted areas. And it's an amazing treatment. And that's something I've been dabbling in the last 10 years, is this Botox treatments for migraine prophylaxis. And patients come every 12 weeks for just repeat treatments.
So how does it work? Because for Botox for chronic pain, I know that we use Botox in physiatry for post-stroke or spasticity patients to make them more functional. So how does that work in chronic pain?
So now I could be corrected. So if someone puts it in the show notes and corrects me, that would be great. But I do not believe we understand the full mechanism of how Botox addresses migraine management. And Botox has been around for a long time, 20 plus years, and it did start a bit more in the cosmetic industry. And what we found was patients getting Botox for cosmetics were getting less headaches. And so they started branching out and treating various muscles around the head and face. And we have developed this protocol, and it does reduce headaches for 12 weeks. So we are turning off muscles still, but it depends on the cause of the migraine headaches. But we don't really understand fully how the Botox turns off the migraines. But it started with this cosmetic industry and patients getting improvement in their migraines, and then it branched out from there until we got this protocol that we use now.
And is it OHIP covered?
It's a great question. The Botox itself is not OHIP covered. The procedure is covered by OHIP. So getting the injections done is OHIP covered, but the Botox itself is not covered. So patients either pay through third-party coverage or they pay out of pocket for the Botox. They pick it up at a pharmacy and they bring it to the office, and then we inject the Botox.
Fantastic. So how did treating migraine patients lead you toward aesthetic medicine?
This was new to me. And honestly, the whole field of aesthetics is not something I'd ever really thought of. Cosmetic patients in the past were getting benefits with migraines, and that's how it brought on this preempt criteria and the development of Botox for migraine management. But in reverse, at the clinic, I'm treating patients with migraines and they're getting cosmetic benefits. A lot of them really love those cosmetic benefits. And my supervisor, Bill, will often do just a couple little touch-ups that are outside of the protocol, just strictly for cosmetic purposes. I learned to appreciate that cosmetic piece to getting Botox. And it's less complicated than people may feel like it's made out to be. I think I became more comfortable with that because we were treating so many patients with migraines. So you get more comfortable using Botox and administering Botox and injecting it into people's face. And that, for me, led down this path of, could I do this cosmetically? And one of our physicians there, his wife's a nurse practitioner who is a medical director for a number of nurse injectors. And I had the opportunity to meet her, and she just in that just a simple relationship, really non-teaching relationship, she said, I think you would be a great injector. She loved your personality, you have the skill set, you're already using Botox. She's, I think you should take some formal training and consider doing Botox on the side. And it took me a little bit of a push because I really wasn't sure that's what I wanted to do, but I did. I committed and I took a training course through the National Academy of Aesthetic Medicine with Dr. Rosati. He's in Vaughan, and I learned some general principles because I was treating migraines. I wasn't doing cosmetic medicine. I wasn't really doing aesthetics, although there was a component to it and patients appreciated those benefits, and we did some subtle, small things. I did not have general guiding principles on cosmetics or aesthetic medicine. And so this course really showed me that side of it. And then from there, it's just been a slow evolution of treating some friends and then family. And then now I have people reaching out and there's a business and things are growing.
I have a friend who's a PA from the States, and she talked a lot about how Botox is a lot like, at least the aesthetic part, it's a lot like being an artist, like artistry. Would you say that's a fair comparison?
Absolutely. And it's something I am still very much learning. I thought I'll take the course and I'll understand how to provide Botox to patients. And you do get these, and I say guiding principles because they're just guiding principles. And very quickly, as you talk to competent injectors that have been using Botox for a long time, they, as much as those principles are there, they are playing outside of those all the time because everyone's face is different. So it's not as simple as landmark, put a certain number of units and move on. It's not like that at all because everyone expresses their face very differently. Different strength of muscles, different movements and different features, whether that's in their forehead or in the crow's feet or in their frown lines and things like that. And some people have asymmetric faces. They just move muscles slightly different than other areas. And there is an art to it. You really need to assess a patient before you can tell them how many units they're going to get or offer them a treatment plan. And this takes time and just seeing. And I'm not an expert here yet. I wouldn't even claim to be close to an expert in this field, but there is certainly in seeing a lot of different faces, I think it takes 1,000 faces before you start feeling comfortable seeing those patterns and appreciating exactly how many units to put in certain places. And then at the same time, patients have different expectation outcomes, right? They want different things. Some people want very subtle transitions and some people want a bit more of an aggressive treatment. And so you have to have this communication, right? Open, transparent communication with patients and what they want and what you can offer them and what you can't offer them sometimes. So I'm learning a lot and I'm growing a lot and I've come a long way, but this is a field that for sure is an art. And I'm not sure if your friend offers other cosmetic treatments as well, but it becomes even more of an art as you start getting into some of the advanced cosmetic injections.
What are some of those advanced cosmetic injections?
Some people are doing fillers and there are other collagen stimulating products you can do as well to help treat sort of some parts of the lower face and the neck. Some people obviously treat their lips. I'm sure people have seen the fillers in the lips and the cheeks. And again, there's very subtle filler and there's very aggressive filler. And then you get into some of the more surgical procedures, like people putting in threads and people obviously getting into plastic surgery and things like that. So, and then there's a lot of the Medi-Spa type stuff with lasers and microneedling and peels and things like that, which are, they're all good things. There's a menu of options. And I'm trying to find my niche when it comes to Hamilton Botox. For me, I'm really looking to treat a subset of natural effect with Botox, and I'm not sure I want to get into the sort of next level of this industry. And I think a lot of people land in that boat, and I'd love to be an expert in that niche and maybe not expand into offering absolutely everything to everybody. But I'm still learning and growing, so I don't know exactly where that niche is going to land, but I'm trying to figure that out.
Well, that's amazing. So it sounds like you founded Hamilton Botox. And I know that at least in Ontario, PAs cannot own independent practices. So you had mentioned that Hamilton Botox is physician directed. So what does that type of model look like day to day?
So just like working in medicine, there are medical directives that I practice under. This was also part of that. I took this course through the National Academy and got some training, but that doesn't give me the right to necessarily go inject Botox to people because I still work as a physician assistant. And so I have to work under somebody's medical directive. I am fortunate enough that one of my colleagues here at ArthroBiologix, her mom's a family physician and offers cosmetic procedures, including Botox in her practice. And for me, I reached out and she was willing to be a medical director for me. And she came and watched me treat 3 or 4 patients and saw my approach and in full complex picture in terms of just counseling patients, having that communication and signing consents and using an EMR and then performing the actual procedure and seeing some outcomes. And she felt comfortable. And so we built a relationship together where I practice under her medical directives. It's not dissimilar to medical directives I would use for migraine treatments in Burlington Pain Care. It's just on a cosmetic side. So it feels different because it's more private and not medically driven, but as a physician assistant practicing, it actually looks the same, which is interesting. And that took a little bit of research because there's not an abundance of physician assistants working in a private industry like that. But I'm not the first. I'm not the first to do this. But it did take a little bit of research and investigating to find out how to do that through the proper channels.
So if you have an experienced PA that is not working in the field of cosmetics and they were thinking about doing something similar, what would your recommendation be in terms of how to get their foot in the door? Aesthetic medicine.
If they are working in a practice where somebody they're working with is already doing cosmetic injections, I think it's a very easy transition because that person's probably willing to be a medical director, or at least I hope they would be. That's probably the biggest hurdle is finding a medical director. I struggled early on because in the Burlington Pain Care Clinic where we treat migraine patients, and as much as they were doing a little bit of cosmetic things, it's not their niche. They don't provide cosmetic procedures to patients on the side. So they're really doing migraine prophylactic treatments, and then patients would get a little bit of Botox maybe here and there for some cosmetics, but they wouldn't call themselves cosmetic injectors working in the field of aesthetic medicine. And so as a physician assistant, you want your supervisor to be in the field that you are practicing in. And so as much as they were qualified to inject Botox, they wouldn't have said they were an expert in the field of aesthetic medicine. And that's what led me to trying to find my current supervisor who does practice in the field and does this on a regular basis. Should the college ever ask me or want to see my medical director, that our practices align and that she's an expert in the field and can certainly provide that expert opinion beforehand with injections or afterwards if there were complications or during a procedure and things like that. So I think if you don't have that niche or that supervisor, someone asking like it's not the field you're working in currently, then reach out. By all means, reach out to me or find someone else that's providing Botox. I think a lot of people can give you good advice, but as a physician assistant, because we practice so uniquely, it's just different, and it would be a lot easier having had somebody that was already breaking these chains and crossing some of these hurdles. So somebody really is interested. And I've had actually a couple of PAs reach out to me just via online messenger through email, but I'm happy to answer those questions.
That's great. Thank you for offering that. That was very helpful. You've worked as a clinician, you've helped co-found a practice, but Hamilton Botox is like your baby. It's a very entrepreneurial endeavor, and it's very different than like seeing patients. There's this whole business side that you aren't necessarily taught in school. So what were some of the big business decisions that you had to learn and figure out on your own?
I feel very blessed and fortunate that I've had some amazing mentors. Dr. Rabinovich included as probably one of the biggest ones, but also some close friends and other supervising physicians. But I don't know anything about business. And honestly, financial literacy for me, I certainly would not claim to be an expert in financial literacy, but as a PA, I think it's important that we're aware of it when we're negotiating or salary building and building our roles within a system. But then starting a business is something completely different beyond that. So as much as I felt comfortable in my worth and value and how to negotiate as an employed PA, starting a business, I actually knew absolutely nothing. And I felt like so naive after I took this training. I was like, okay, I'm gonna take this training and then I'll be able to provide Botox to patients. But I was like, wow, there are so many steps that go into it. And I can appreciate why so many people may be out there with a dream that want to be entrepreneurs and they never pull the trigger because it is so intimidating and there are so many steps. And if you don't have people helping you along the way, it can be just very hard to figure out on your own. So what is it for me in terms of the biggest decisions I've had to make? One was actually incorporating. How do you become a business? Like, how do you actually start a corporation? And I have a close friend who's an accountant that helped me just go through the steps of incorporating and then filing taxes for the first time. And then it's how do people know who you are? What does that look like? And social media is not my jam at all. I appreciate that it's something that's part of the role and part of people finding you online, but it's not something I'm inherently good at. So how do you create a Google business profile? How do you create an Instagram page or a LinkedIn page? Like, how do people find you? Developing a web page that people can land on and see some of your work and get to know who you are before they make a call to find you. How do you set up a call? How do you get a phone, and how do people reach you and contact you and leave messages? And then the other thing was like, how do you actually order supplies? I'm sitting there and I'm like, how do I actually give Botox? And then as a physician assistant, especially, I found it very hard to reach out to these pharmaceutical reps and be able to order Botox. And so I had to find a third party connection to order Botox. And then you got to order supplies. And then the other big piece of it is businesses are not profitable up front. It's very challenging. There's a lot of these steps have costs associated with them when it comes to incorporating and just getting some of those resources built up in terms of supplies. So there's a big personal investment up front, and then there's a lot of these steps that I was just naive. I did not know that they existed. And so I feel fortunate that I've had a lot of people help me with those steps, even just the accounting and sort of understanding revenue generation and expenses, risk management. So there's a lot that goes into starting a business. And I think if I had in some ways been aware of all of those steps up front, I actually think I would have been more hesitant about pulling the trigger and starting it. But I've just taken them in stride now. Every time something's come up, I'm just like, okay, let's sort this issue out and move on. But there's a lot that goes into it. If you overthink it, you could talk yourself out of it just because the more you think about it and the more steps involved, it is daunting. But there's people out here that have done it before. So you're not paving the path for the first time. And I think there are people that are willing to help, even if you don't personally know them.
So if someone were to be interested in starting a business, what would you recommend as first steps, or how to gain a little bit of knowledge or support in that journey?
There are companies out there that will help organize a business for you from start to finish when it comes to creating a business name and incorporating and filing taxes for the first time. And I think that could be very helpful if you had nobody that you knew that did these things. Also, just reaching out to an accountant, having an online, there's a lot of GoDaddies and things like that will create websites and platforms for you and then help you incorporate as well in terms of having that name. And then having an accountant is just, it's so helpful. They just do so much. And I was fortunate because I had some help along the way that just saved me some of these expenses. But you can definitely find these resources. But then again, they all have a price associated with them. Certainly, I would not try to do it on your own. That would be my biggest. I couldn't imagine having. I don't even know if I could do it again if you asked me to do it on my own. It's very complicated. And so I think asking for help and hiring help is a necessity. I don't think you should try to do these things by yourself.
It takes a village, and I think as much as it takes to grow a PA, you can't do it in these silos. It's being the best version of yourself is surrounding yourself with people that can help you grow.
I like to focus, and I tell people, like, I like to focus on the things I'm really good at, and that's here and doing Botox and seeing patients and doing injections. And there's things I'm not good at, and that's social media, online business development, and accounting. There's people that are experts in this field. So let the experts do their thing and focus more on the things that you're passionate about and that you're good at. So I think that's the right way to go for most things.
And I guess that's the key to happiness, just focusing on your zone of genius and outsourcing the rest. All right. With that being said, you do manage multiple clinical identities. You've had parallel clinical roles across very different practice environments for years. So how do you manage that without it becoming unsustainable or burning out?
This is a good question. And I've flirted with burnout in the past. And even just stepping into a leadership role through ArthroBiologix, when you graduate and you're starting, I think it should be your main focus. And you're learning so much. We talked about that 6 months to 2 years to feel comfortable and really competent and an expert in your field. But there are expectations when you're working and you're employed to get a certain amount of work done, to see a certain number of patients, to perform a certain number of procedures. So there is an expectation at work to get a certain amount of work done. And then as you grow and you take on, say, a leadership role where I'm training PA students, even as an initial base, you're bringing on a 4-week placement or something, that expectation to get your work done and see so many patients and do so much work in a day, it doesn't go away. You're just adding the student and that work on top of that. And so I am not amazing at organization. It's not my strongest suit. I have learned to become better at organizing and time management. You need to be efficient when it comes to work and finding ways to be as efficient as possible when it comes to paperwork and seeing patients and just getting some of those simple things, tasks done in a day. But I enjoy having patients, or I enjoy having students. I enjoy having those clinical placements come through. And so that brings me joy. As much as it's more work, I enjoy it. And so I do it. And you learn to balance it and you schedule your work life a little bit more around those things. So I may book less Botox things, and I may not try to do as many meetings and stuff that week. So you need to balance. There's a give and take when it comes to work. But I feel in a place at work, at least in ArthroBiologix and in Burlington Daycare, where I'm very competent in my job and I'm very skilled at the technical work that I'm doing, that I don't spend a lot of time thinking about my procedural things during a day. I think when those things can become a bit more second nature, you start to relax a little bit and you have better conversations with patients, and you're able to communicate better with your colleagues and my students and with Dr. Abhinav and the people that are trying to build ArthroBiologix and some of these decision making that we're doing on the side, things like that. If you were to always feel stressed in the work you're doing on a day-to-day basis, I think that would lead to the burnout. So I feel fortunate in the sense that the skills that I'm doing on a day-to-day basis, I feel very comfortable with, and I'm able to just spend more time talking to patients, whether that's related to their symptoms or just about life. I get to have good conversations every day. So that's a big piece. Adding Hamilton Botox on top of all of this has been a lot, but again, it's something I'm very passionate about. I'm not sure what that looks like. In all honesty, it's very new to me. And it's not taking up an abundance of time because I'm still very fresh and it's not a big clinical practice for me at this stage. But as it continues to grow, as I hope it does in the next months to years, I'm going to need to juggle that. You can't do everything, and you can't have your hands in every single pot, because I think you will burn out no matter how much value you put to that and no matter how much money you're making. It does not shield you from burnout. So it's something I'm always thinking about and trying to balance. And I have an amazing wife who balances things as well. And so we try to balance each other. But yeah, it's a good question, Anne. And I think it's a constant change. So you always have to sit back and reevaluate and see where things are at. And everyone's different. Everyone's got a different threshold and handle different amounts. I don't know. It's a good question. It's a personal question for each person, but you should, as anybody out there that's thinking about being a PA or is a PA, you should definitely be self-reflecting all the time on these types of questions.
Actually, while you were speaking about that, it made me think about how some PAs or pre-PAs pursue the PA profession because there's better work-life balance. Would you say there's such thing as that, being a PA or any other healthcare provider for that matter?
I am personally seeing more new grad PAs do it better. I'm seeing that, and I think that's a great change for many people that want to be PAs or are just going through the profession now. Anne and I have been doing this for 10 plus years, and I think what physicians saw PA as when we first graduated was the expectations were very high, and we weren't that willing to push back because there wasn't an abundance of places you could go and do. So you just had to take it a little bit in stride. Whereas now I think there's more opportunity, and PAs are able to better leverage those opportunities. With more opportunities, there's more leverage, and PAs know their worth a bit more. And I think OrthoPA network in the PA consensus salary that goes around is an amazing resource for PAs to have an idea of where they should be starting and how they should be growing. And I think this next generation of PAs value their time more. I think people are willing to come to work and work hard, but they don't want to work 60 hours a week, and some maybe do, but I think people are finding that balance, and not every employment opportunity is going to allow people to do that. But I know for us here, it's something, we have PAs that work 3 days a week, PAs that work 4 days a week, PAs that work 5 days a week. And so it works. And we have PAs that are very casual part-time actually that work 1 or 2 days a week. So I think you can find it, and you got to balance that with your own personal financial life goals and decisions and family and things. But I think it's more possible. And I think in terms of the workload itself, when you're at work, I think it's extremely variable. I think that everyone's busy and medicine is not easy and resources are very limited. And this next probably 2 to 3 decades is going to be extremely busy and create a lot of burnout for providers because there's not enough providers and there are a lot of patients. But I think there's something to be said for providing that care and being in it. But yeah, it's that piece of it in terms of the day-to-day grind and actually being at work. It's challenging. You got to find the time outside of it. That the work itself is always busy, for sure.
Yes, that's a great answer. So it's a good thing that they're growing the PA profession across Canada, adding more schools and adding more spots to the currently existing programs. So you've mentioned OrthoPA a couple of times. So can you tell us about what OrthoPA is and what your role is within that organization?
I guess maybe 3 years ago, Hood tapped me on the shoulder and asked if I would be a member on the OrthoPA network as a finance lead. And for OrthoPA network, I love what Hood's doing, and she is creating OrthoPA network as a sort of a community hub. It's developed by PAs, it's for PAs, and we want to encourage learning and collaboration among ortho PAs. There's a lot of us now, which is amazing. And so it's bringing that community together and creating a learning environment suited for PAs in a way that we can provide it for free, ideally, or at very low cost. Now, in order to be able to do that, we have to find resources. These things are not done for free, and then so we have to be able to find that money and resources somewhere. And so that's part of my role with working with the Hood, is to find sponsors. And a lot of times those are pharmaceutical reps or industry reps that come alongside us and either advertise through us or just partner with us. And they'll often run events or sponsor events. In return, they may get an opportunity to speak to PAs and develop a pool of people that they can show their product to. But in doing so, we're able to provide education for free a lot of the time and or at very low cost. I love what she's doing there. And it's an opportunity to really not only have the free education, but build this community of PAs that can collaborate together.
I love that. I think that CME, or continuing professional development courses, our credits are a requirement for maintaining your PA license here. And these tend to be very expensive. So it's so nice that they're able to offer it for free. And now, just changing gears a little bit, if you were to speak to your 2013 new grad self, what would you say?
I've given this some thought actually recently, and I would tell myself it's worth it. Medicine is hard, like we talked about. It's busy and it's a grind, but I wouldn't change my decision. I don't regret becoming a physician assistant at all. It's very hard, but it's very rewarding. And I loved watching the transition as you even more, but I was the 4th graduating class, and I believe you're like the 2nd class. We've seen PAs grow so much and just change the entire field of medicine. And when we graduated, a lot of people didn't know what a physician assistant was. We spent every day with 80-90% of our patients trying to explain what a physician assistant was before you even got into your spiel about trying to treat them. And now it's rare that I meet someone that hasn't met a PA or been treated by a PA or at least know what a PA is. It's actually very rare now. I love that we're part of that groundbreaking new profession. And I love the satisfaction I get out of work. I enjoy it. I would not go back and change anything. So I would tell myself it's worth it. Being a physician assistant is awesome.
That's great. But you would have taken the same path anyway, it sounds like. You wouldn't have changed anything about your path.
It's hard to know. I like where I'm at, but yeah, could I go back and graduate and tell myself something different? I don't think I would. Again, and this comes down to people who are like, you can't shoot for the stars when you graduate. You don't know what's available to you. You have to start somewhere, and you start in whatever field you feel passionate about. And I think if you're passionate about your work, you love being a PA, and you work hard, doors are going to open and opportunities are going to present themselves. And there's some risk tolerance, but being willing to walk through some of those doors and take some of those opportunities. I wouldn't say I wouldn't have dreamed that this is where I would be at in 2013 graduating. So if I could look back and see myself in the future, and it'd be amazing. Honestly, I love where I'm at, but I don't think I ever graduated hoping for this. That's not, this, even where we're at now as PAs, it was hard to even see that. And this is sort of 12 years later. To think of where 20 years from now is going to be for the PA profession and the PA education program and on Canada, it's amazing.
Yeah, I was speaking to some new PA grads from programs that were just established in new provinces. I know that Saskatchewan is new, Dalhousie, Calgary. They're now a few classes into it, but so a lot of them are experiencing what we experienced as part of the first couple of classes. And so there's a lot of challenges being part of the generation of PAs that are helping to pioneer the profession that isn't necessarily familiar with them. What would you say to them with regards to not getting discouraged in the beginning, or like what they can do given the journey that you've gone through?
Wow, that's a good question. Yeah, I think it's amazing that we have so many schools that are popping up and graduating PAs. I feel bad for the educators. I think it's the hardest. Just starting these with so little resources and trying to establish a program from scratch is so hard. And I look at where McMaster's and Toronto's physician assistant education programs are at, and they've been around for 15 plus years. It's a lot of work that goes into that. So I think for the educators out there, please building these tools, right? Because these are the tools we need in order to put PAs out there. And that's for the PAs themselves, strong and steady in terms of the profession. I think it's an amazing profession and people will see that, but it can be defeating at times when you're explaining your role as a physician assistant and people don't appreciate that or understand what that is, and you're responsible for educating the general population. But on the other side of that, you are the leaders of the profession at this time, and you will be ahead of everybody else, and that presents opportunities too. So for the people that are pioneering it, you're ahead of everybody else. And a lot of times that leads to opportunities that others may not get, whether that's in the program and teaching or just groundbreaking in professions like what I'm doing with niche markets and starting entrepreneurship roles and things like. With challenges come opportunities. So trying to seek some of those opportunities.
Yeah, that reminds me of when I was the first PA in the hospital.
Yeah,
A
that's
little bit
wild.
intimidating. It's
Yeah.
crazy. And now I was like one of three in the department.
It's one thing explaining to the general population, but even in medicine, they were like, what's a physician assistant? What can you do? What can't you do? That's a whole different conversation along the same lines, but yeah, different and also very challenging.
One of the last questions I have for you. So I actually have had orthotic surgeons come up to me and ask me about hiring a PA and what's involved. Some of them make the comment that PAs are too expensive. So within the context of Ontario, which is fee for service for surgical specialties, and what would you say to that? What's the feasibility of integrating a PA into a practice or department?
I've also had similar conversations and heard similar arguments, and hiring a physician assistant is an investment. And I would, for anybody that this speaks to that, I would just pressure them to come and just have a look at ArthroBiologix and having 8 physician assistants and just how it's possible. But it's an investment and it's a partnership. I think you're hiring a colleague that is going to hopefully continue to grow with you and be part of your practice for a very long time. I think financially, there are incentives to have some funding for a physician assistant, even for 6 months now, that can get that first 6-month period, which can be that's the window where physician assistant, you just don't feel like you're providing that feedback in terms of finances, the financial incentives. But once you get through that first 6 months, having a physician assistant can change your practice so much. Whether you just want improved quality of life and you want to reduce your workload by 20-30%, maybe more, depending on how good of a physician assistant they are, you could just take the cost and use that as quality of life. I think a lot of people out there, that's what they're looking for, is quality of life, so they don't feel burnt out. And at the same time, that's not what you're looking for. You're looking to reduce your workload a little bit, but you want to have a financial wash. You can see more and do more. Physician assistants are as valuable as the best fellows out there. There's no doubt that financially, the fee-for-service model, a physician assistant can bring in equal or more than their value and worth, on top of reducing the workload for a physician. But I think it needs to be a partnership, and I don't think you can hire a physician assistant to simply do all of the grunt work and the less meaningful side of things, because you're going to burn them out and you won't have a PA for very long. So there needs to be a partnership model in there. You need to be a team, not an employee type of relationship. And at first, it's always going to start like that. But I think the best PA teams that I know, they work together. They make decisions together, and it's an open communication. I don't think it's a secret financially. I think PAs now have a much higher level of financial literacy. They understand fee for service. They understand the money they bring in. They understand their leverage within the system, and that allows them to negotiate better. For any physician that's looking to it, I don't think you would ever regret it. I don't think any physician's going to hire a PA and take a financial loss. And I would be happy to have this argument with any physician and conversation anytime, as I have many times, because I hear that argument a lot, and I don't think it's founded on anything, really. There's just like lack of understanding on the models and how a PA works.
Yeah, I think it's interesting to say that, like, it is an investment and you get what you put in. So with that being said, what kind of mentoring or onboarding can employers do to help like train PAs up to be like force multipliers in their practice and to retain them long term?
In our model now, we have so many staff that PAs bounce around. So I think it's possible at the beginning in a group that maybe is unsure how to use a PA full time is to have a shared model where you utilize a PA between 2 or 3 practitioners. And I think the best way to get your value out of a physician assistant is to not expect it at the beginning and to really treat them like a resident and a new grad or someone that's coming through a placement, because going back to our initial conversation, I felt incompetent at the beginning. I was not useful and I wanted to be useful, but you just don't know how. And like every placement in clerkship, you spend 4 weeks. And by the end of 4 weeks, you feel like you're like, you know what, I can do some of this. And then you get pulled and you go somewhere else and you feel like you got to do that all over again. And graduating as a new grad, you feel very similar. And I think some employers want to recoup that loss right away. And they don't feel like the PA is providing that service right away. And that just needs to be an expectation. There needs to be an understanding that it's going to take 3 to 6 months for a PA to be able to provide something very worthy. It's a very gradual transition over 3 to 6 months. And for us here, we expect nothing for the first 3 months out of our PAs. They shadow, they learn, and they start to do a couple of procedures under supervision. So they actually are not even speeding. They're really, honestly, for the most part, slowing clinic down. But then you see the transition happen and they can start, and they're very good because you've taken the time to teach them, to show them the skills to create technically competent injectors, and they learn and they see and they do. And once you've honed those skills into them, they're still learning and they're still going to shadow, but they have a great groundwork to then go and see patients. And you don't get stuck in this lack of understanding or learning, because there's nothing worse as a PA. You end up doing the same one thing you've learned to do well, and because no one's showing you anything else, you don't ever really learn it. You try to figure it out by yourself, and it takes a long time. So there needs to be this period of investment to make them really well trained in the things you want them to do.
And what can PAs or PA students do to advocate for their own learning?
I think I would have that conversation right up front. And I think, fortunately, a lot of PAs are getting hired into fields where they've already done placements, and that's helpful, or they're going into fields where there's already PAs practicing. So I think the hurdles are a lot less, at least here in Ontario, there's a lot less hurdles, but certainly don't be afraid to advocate for yourself and to know your worth and to leverage that. I think we have this amazing community now, and I know I brought it up a lot of times, but the OrthoPA network is amazing, and there's PAs working in every aspect of orthopedics. Like, I'm in private outpatient orthopedics, so I can't necessarily help someone that's necessarily going to a hospital as well as somebody else, but we have PAs working in every field, every imaginable field out there, and you don't have to reinvent the wheel. And I think you can have these conversations and then take that knowledge and go back and have an open conversation with your supervisor. And if it feels not right, it's probably not right. I think people are a good judge of character, and as much as physicians are looking for someone that they can work with and share that work with, we also have to share that work with a physician. That relationship goes both ways, and I think PAs need to like who they're working with, because that's a recipe for burnout as well. If you don't like going to work because you don't like who you're working with every day, it's just, you can love your work, it's just hard to do. When you work because we work so closely with those physicians, right? You want to have somebody that you get along with. And not every personality meshes with everybody's personality. I think you feel that out in the interview. And one thing we do here, which I think may help a lot of people, is that we do a 1 or 2 day shadow placement for people that we interview. Before they commit to anything, if they want to just come and spend a day with us, they can do that. It allows us to feel them out, and it allows them to feel us out. They get to know the staff a little bit. They get to know how things function. It's almost like a better interview. And then both parties can say, you know what, that was great. Let's give this a try for 3 months as a probation period. So that works for us very well. So I think if there were staff that were open to a day or half a day of just saying, come and see what we do here, I think you gain a lot more than just the basic interview.
Yeah, you get to see how they interact with staff, how approachable they are. I think people present differently in an interview that takes place over 15 to 20 minutes over a Zoom call versus being in person.
Yeah.
So I really appreciate that. That's such a great idea. I think we've definitely gone over time, but that's okay. This was great, by the way. So thank you so much for your time, Justin. I really appreciate all the knowledge you had to share and walking us through your journey. So where can listeners find you or learn more about the work that you're doing?
ArthroBiologix has its own website, ArthroBiologix.ca or .com, and you can see our whole team and what we're doing here in terms of private outpatient medicine. For anybody listening, I would absolutely love the following on Hamilton Botox, even if you're not interested in Botox, but just curious about how I do things or how Botox is done or what is Botox or what are PAs out there doing. I would love the following. So that's at Hamilton Botox on Instagram. I do have a website as well, hamiltonbotox.ca, but the Instagram handle would certainly be the best way to find me and see some of the stuff I'm putting out there in terms of videos and footage.
Okay, cool. And people can find that information in the show notes. So we'll also include Justin's email as well. Thanks so much.
Thanks, Sam.
Thanks for watching or listening to this episode.